Okay, well, thank you all for being here. I know how busy you all are between clinic and research and families. You just had a baby 5 weeks ago. She's here after delivering 5 weeks ago. That deserves a round of applause for sure. Okay, why don't we start with some introductions? Sorry, you have to just switch it to the left.
Okay. Hi, everyone. It's great to be here. My name is Kornbluh. I'm one of the pediatric neuroimmunologists at Children's National Hospital. And yeah, it's a pleasure to meet you all.
Hello, I'm Dr. Ilana Kahn, also from Children's National Pediatric Neuroimmunology. Thank you for having us today.
I'm Bob Shin. I'm at University of Virginia in Charlottesville. I do neuroimmunology and neuro-ophthalmology.
And I'm Elias Sotirchos. I'm at Johns Hopkins University in Baltimore. I'm an adult neurologist.
Yeah. So it's great. We have two. Oh, yeah. All right. So let's just dive right in. I'm going to start with you, Dr. Sotirchos. Can you tell me what is the current definition of NMOSD? How would you define it?
That's a great question because there's actually an ongoing process to revise the diagnostic criteria right now because the current criteria that we have are from 2015 and that's a bit outdated, especially since the MOG antibody and MOG antibody disease has kind of come to the forefront since then. I would say that currently, in terms of neuromyelitis optica spectrum disorder, it's currently defined as somebody who has had optic neuritis or so optic nerve inflammation, myelitis, spinal cord inflammation, or inflammation in other areas of what we call the central nervous system. Sometimes people can get at the base of the brain, which causes this syndrome of hiccups, nausea, vomiting called area postrema syndrome, and then also has a positive blood test for the aquaporin 4 antibodies. So people have with those, a combination of those findings are given a diagnosis of aquaporin 4 seropositive NMO. SD, so spectrum disorder. And again, that antibody targets this aquaporin 4 is a water channel that's located on cells in the brain, and this antibody is what causes the disease. Now, one of these areas that's still, I think, being explored in terms of the diagnostic criteria is for people who are test negative for that antibody. There, the criteria currently require that people have had 2 attacks or at least involvement of 2 separate parts of the central nervous system. So, for example, optic neuritis and myelitis, because again, the antibody isn't present there to kind of clinch the diagnosis. And then this has been a little bit more complicated since it was recognized over the past decade that MOG antibody disease, which is this antibody that targets MOG, which is located on the myelin sheath, so the insulation of the nerves in the central nervous system, accounts for a proportion of the people who have seronegative NMOSD. And so now the criteria are being revised in order to kind of carve out these different categories.
Perfect. Very good. Dr. Kornbluh, can you similarly define MOGAD for us?
Yeah, absolutely. So MOGAD stands for myelin oligodendrocyte glycoprotein antibody associated disorder.
That's a mouthful.
So that's why we call it MOGAD. And similarly, there are diagnostic criteria that were actually just recently published a couple of years ago to try to sort of like encompass all of the patients that have MOGAD. First and foremost, it is a clinical diagnosis. And so you have to present with one of the sort of like classic clinical attack types, like an NMOSD. And in MOGAD, that also includes inflammation of the optic nerve or optic neuritis, inflammation of the spinal cord or transverse myelitis. And then there are some other features in MOGAD that we don't typically see in NMOSD. So particularly in children, we can see something called ADEM or acute disseminated encephalomyelitis with widespread inflammation in the brain and spine. And then some other less common but sort of more emerging phenotypes that we see in patients like inflammation in different parts of the brain called cortical encephalitis and others. So once a patient has first presented with one of these different clinical attacks, they can be diagnosed with MOGAD right away if you have the positive blood test for MOG. it depends on how that blood test is done and sort of how high the MOG antibody level is in your system, if you can reach the diagnostic criteria right away. If you have a low level of the antibody, or if you don't have access to the appropriate testing, or depending on how that lab is done, there are some other more nuanced criteria to allow you to reach that diagnosis based on sort of what the scans or MRIs show, and you have to have sort of classic features of that inflammation in the optic nerve, the spinal cord, and the rest of the brain.
All right, thank you. Dr. Shin, I want to talk about diagnosis now. So can you tell us some of the common symptoms that you see when folks first come in to see you, and what does the workup look like to a diagnosis of tests, imaging, labs, etc.?
Sure, yeah. I did actually want to kind of say, I feel as though we, as a field, we missed an opportunity when we talk about these conditions in a way, because there is a common thread between NMOSD and MOGAD, and even other conditions like multiple sclerosis, and that there is inflammation in the central nervous system, right? Brain, brainstem, spinal cord, optic nerves, that causes these episodes or attacks. That's just sort of in common with all of these conditions. And I'll give you a different example in a different context. In neurology, I don't know if any of you have heard of a condition called myasthenia gravis. It's just a description of someone who has muscle weakness, and it gets worse with time or with fatigue. It has sort of a clinical picture that you would recognize. And we've learned that there are different antibodies that can create that phenomenon. The most common one is antibodies against acetylcholine receptors. But we later learned that you could get antibodies against something different, MuSK, muscle-specific kinase. And in that world, we just call it myasthenia gravis, but we recognize that some people have antibodies to this target and others to another target. And some people don't have either antibody but still have myasthenia gravis. And that's actually what we're dealing with here, right? Look at the kind of, I don't want to call it confusion. I mean, these are nice letters. But people share the same presentation. Something takes their vision. They lose vision in one or both eyes. Or they suddenly develop weakness, maybe in the lower body or maybe one side of their body. Maybe they have some other kind of funny brainstemmy thing. That could be nausea and vomiting. That could be a double vision problem. And we recognize, there's inflammation going on in that area. And what we've learned is that some people have antibodies to aquaporin 4, the water channel. And some people have antibodies to myelin oligodendrocyte glycoprotein, MOG. And some people have antibodies to neither. But it's all part of that spectrum. So it's a little bit of a shame, in my opinion, that we've sort of created different names because it creates confusion when there's a lot more that is in common than that is different.
We feel the same.
Yeah. But to answer your question, to answer your question, as we mentioned, vision loss is common. Weakness or numbness is common. Double vision or dizziness can present that way. You asked about workup, and I think you know, again, what's in common. Almost every patient in this scenario will get an MRI, will get imaging. That's what's often going to identify that inflammation in that area. And I think through the work of your foundation and others, we're increasing awareness. It is really critically important to check for those two antibodies, at least the ones we know about. And that, I think, in a nutshell, is really how the testing is. That's why, actually, when you ask in this room, everybody is antibody positive, because that's how they got in this room. That's how they found out that they had either NMO and MOG, or MOG.
What about like spinal taps and all the other stuff that's involved in the diagnostic journey?
Are you asking me? Spinal taps, it's interesting, because I'm actually the oldest person on this panel.
You don't look it.
Thank you. That's so kind. But I remember a time when everybody in the workup of these conditions was getting spinal taps. Actually, almost anyone who showed up in an emergency room with a neurological problem ultimately got a spinal tap. And then they kind of fell out of favor. I mean, people get nervous. There's a needle in your low back, and you're drawing fluid, and I don't want to get paralyzed. You know, people are scared. There was a time when actually I would say, I don't know if you all would agree, but it seemed to like take more of a back seat. It didn't seem as though we needed spinal taps all the time to make the diagnoses we were trying to make. But it has come back in sense, and we didn't really say this, but a lot of these conditions, NMOSD or MOG, although we're trying to avoid saying it, it's actually the inverse of what is more common in the United States, which is multiple sclerosis. So people are evaluated, and often, I'll be honest, mistaken as having multiple sclerosis. Sometimes they're even treated for multiple sclerosis, and some of those agents actually might even make their condition worse. And so lumbar puncture has, I think, become more important because it's increasingly important for us to get the diagnosis correct at the very beginning.
Thank you. Dr. Kahn, can you talk about prevalence and incidence rates of both disorders? So like how common is NMOSD? How common is MOGAD?
So, I mean, we're talking about rare diseases as a whole. I think what Dr. Shin just mentioned is multiple sclerosis is sort of the bigger disease in the room that is under that same umbrella of demyelinating disorders, right? So we're looking at something has caused that inflammation or that demyelination. Is it under the multiple sclerosis bucket in which it's going to behave in a certain way, right? We've sort of identified that it relapses in a certain way, it responds to certain medications, or is it under the NMOSD or the MOGAD umbrella? So MOGAD and NMOSD are certainly the smaller of those, but we're still talking about very rare diseases. In pediatrics, we're talking about even smaller numbers. Yeah. I mean, it's really hard to even quantify at this point. I think one of the other really interesting things to me, and I probably comes up a lot in your world as well, is that this is a disease that is probably happening across the world and is really also very under-recognized, right? So when we talk about our workup and how we identify this, we're talking about we're getting an MRI, we're doing all of this testing. And for anyone who's spent time in other parts of the world, that is not available. Right? And the quality of the MRI is not there. You're paying out of pocket for it if you can even find somewhere to do it. People aren't thinking about it because these diseases were also first identified in Europe and in places where, from a diversity standpoint, you know, we didn't think that people could get MS who lived in Africa or somewhere else, right? So, so the answer is these are very rare diseases that are probably happening more commonly than we even realize.
Yeah. Okay. Dr. Kahn, let's talk about demographics. Can you speak to how these diseases manifest for children, since you're a pediatric neuroimmunologist? Yeah.
Absolutely. We see far more MOGAD than NMOSD in our pediatrics clinic. So NMOSD is only about 3% of children who present with a demyelinating disease. In MOGAD, we think it's somewhere between like a third or maybe even newer numbers over half of children with MOGAD. And so in I'm sorry, what was the question?
Just like how common is it for children? She kind of, talked about it, but like how does it manifest for children? How are you treating the children? Because they're not able to get the treatments that the adult patients are able to.
Yeah. So in the setting, so MOGAD is much more commonly seen in our clinics, and children do in general present in similar ways to adults, but the sort of proportion of children who present with those different clinical attack types is different. So the most common presentation of MOGAD in children is ADEM, that clinical phenotype that I mentioned before, so acute disseminated encephalomyelitis. Children with ADEM present with a whole variety of different symptoms. The hallmark is that they have to have something called encephalopathy, meaning they're not acting like themselves. So they're either very confused or sleepy or sort of out of it, sometimes irritable or agitated. And then on top of that, they can have other symptoms such as vision loss, paralysis, numbness or tingling, trouble walking or sort of wobbliness, what we call ataxia. So they can have these sort of whole host of symptoms, and then we confirm that diagnosis with the MRI and the blood testing for MOGAD.
Okay. Dr. Shin, back to you. So story time. The first time I met Dr. Shin was on the patio at this conference called ACTRIMS in West Palm Beach. And you were the very first person who ever told me about like how MS was considered like the European disease and that NMO was far more prevalent in Asia. So I learned a bunch about that from you. Can you share with our audience about like the demographic breakdown of the diseases? Like where does it affect people more or less, age, gender, that type of thing?
Sure. So I was sort of alluding to that a little bit when I mentioned in the United States, we often are focused on multiple sclerosis, and because we're in the U.S., we talk a lot about it. Actually, my title in my university is I'm the head of the division of multiple sclerosis and neuroimmunology. It's such a sort of common thing that we see here in the US. And it just, since we were talking numbers, we actually were underestimated. About 1 in 300 Americans has MS. So about 1 million Americans have MS, we estimate. That's a lot. Yeah. The incidence and I guess prevalence of things like NMO spectrum and MOGAD is much lower than that here in the US proportionally, but not really worldwide. So as was already hinted, if you go around our planet, it does not matter your ethnic origin. It doesn't matter if you're black or white or Asian or Middle Eastern or what have you. There is a very similar risk of developing either NMO spectrum or MOGAD. Now, there are some differences, but within like an order of magnitude. And given it's hard to count the numbers, I would say it's pretty close. And what this means is when I was in training, now this is back to being old, I learned about multiple sclerosis as a demyelinating central nervous system condition. I learned that there was a subtype of MS, where it was weird because it looked like they had MS because they had optic neuritis, vision stuff, and spinal cord stuff, but their brain had no lesions on it. It was completely normal. And that's what we called NMO. There was no spectrum at that time. There was just this weird variant of MS, we thought. And I was also taught, I'm a Korean person, and you know in Asia, they get MS, but not like MS in the West. They get Asian MS. And I was taught that Asians, Koreans, Japanese, East Asians, Koreans, Japanese, Chinese people, would get MS, and it would be optic nerves primarily and spinal cord. So we called it Asian MS, or we made up another name, opticospinal MS. I was like, well, that's interesting. So again, it was not until about 20 years ago that the antibodies to aquaporin 4 were identified, at which point you immediately were able to do, oh my God, Asian MS is just NMO. Yeah. We never made that connection before. Like, oh, it's as if anybody, any human being on this planet, occasionally their immune system will start to target aquaporin 4. And it does not matter what your race is. That isn't actually true about MS. This isn't what we're talking about here, but it's super common here, but I'm just going to say it's most common in black and white Americans and Europeans. There's something different about MS in terms of the populations that target. I'm just going to be honest and say in the US, it isn't as common for someone of Asian ancestry to have MS. It actually isn't as common for people of Hispanic ancestry to be diagnosed with MS as black and white Americans or people of Northern European ancestry. In fact, some people have said, you know, the way you can identify the risk of MS, actually it isn't skin color. Actually, for a long time in the US, we underestimated the fact that black people get MS. It's kind of a classic bias that we had. But they said it's not the skin color, it's your last name. If you have a European last name, your risk of MS is much higher. Because black Americans in the US typically have European last names for historical reasons. But immigrants or people descended from immigrants tend to have different last names. So the last thing I'm going to say about the demographics, which I think is a classic, another mistake that we do. When people learn about multiple sclerosis, you're physicians, you learned about MS in medical school, and you probably learned that MS primarily affects women of the Northern European ancestry, white women. We emphasize that a lot, and it is technically true that more women than men are diagnosed with MS, a little bit more, 2 to 3 times as many. What's weird is that we don't emphasize that with other conditions, like NMO spectrum disorder. We teach people about it, but we rarely emphasize that more women than men are diagnosed. You mentioned your ambassadors, 80–90% of them are women. Yeah. Because in our clinical trials, 70 to 90% of people diagnosed with NMO spectrum disorder are women, not men. Men get this, by the way, and they're at risk of being undiagnosed. But it's sort of a weird thing to me that why do we emphasize it so much with MS, which is merely 2 to 3 to 1, and we don't emphasize it in conditions like NMO spectrum disorder, where it's much, or for that matter, lupus. If you've ever heard of lupus, SLE, you learn about it. As a medical student, I've sent ANAs on lots of people, blood tests to rule it out. Almost no men get lupus. We don't talk about it that way. Pseudotumor cerebri, a neuro-ophthalmologic disorder. I get referred all the time, men for, I'm like, the one thing the man does not have is idiopathic adrenal hypertension. So there's still a lot more education I think we could do about this.
So fascinating. Thank you for that. Dr. Sotirchos, I have a couple of hard-hitting questions for you. So the first is, can you debunk this myth of having MS and NMOSD or MOGAD at the same time? Is that possible?
That's a good question. So as Dr. Shin alluded to previously, there has been some kind of thoughts in the past before it was recognized that NMO kind of is its own distinct disease with a specific antibody in the bloodstream that's causing the disease, and people conceived of NMO as being a variant of multiple sclerosis. So it's been recognized since 2004 when that antibody was discovered that NMO is a different disease in terms of that the cause of the lesions is different than it is in MS. And I'd say that that's being very kind of thoroughly examined, and NMO and MS are now considered to not even overlap. If you were to create a Venn diagram, they don't really overlap. I think with MOG also, in general, most people do have a distinct disease. There are some very small number of patients, though, where there is somewhat of a gray area, and I think this speaks to there is some nuance with interpreting the antibody testing to some extent. The NMO antibody in general is much more specific, and what we mean by specific is that if it's positive by what we call a cell-based assay, which is the gold standard for testing, the likelihood of somebody having NMO is essentially 100% as long as they have the appropriate clinical presentation. So an optic neuritis with that antibody being positive by a cell-based assay. The problem with the MOG antibody is that there is a gray area, especially with people who have kind of low levels in the bloodstream. It's been recognized that if we were to test kind of people who don't have MOG or MS or some disease like that, that you can find about 1% of people will be positive at kind of a low level, even somewhat unhealthy controls, healthy donors may be positive. And so in MS, if we were to test everybody indiscriminately, we might find a small percentage of people who are positive. Now, that hasn't clearly, there haven't clearly been kind of cases, I would say, like in some of these big studies that have said, oh, these people have a different type of MS. But we do see, I have seen, I would say, several patients who kind of have some features that are classically associated with MOG antibody disease. For example, we look at the optic neuritis and we say, well, this is a very long optic neuritis and there's a lot of swelling in the back of the eye, which is kind of classic for MOG. You don't really see it that much happening with MS, but then they also have brain lesions that look like MS. And so I think that that's still evolving. Again, it's a gray area. I'd say it's relatively rare overall, but there are some people who seem to have overlapping features and could conceivably even have both. And I think that if you think about it, MS is a very common disease. So 1 in 300 people in approximately the MS are estimated to have it, so about 1 million. So by coincidence, it is possible that people could have both, although there could also be some sort of kind of shared predisposition potentially too, if that makes sense.
But you don't see it often in your clinics.
No, I would say it's rather rare, and I think that a lot of these situations where I see that happening, it's often in my mind been, I see these patients for a second opinion who have been given a diagnosis of both, and we end up revising that diagnosis. But it does exist, but it's relatively rare. I'd say most cases where that's discussed might be a misdiagnosis, but you have to be careful, and we're still learning about this, I would say.
All right. Audience poll. Raise your hand if you have more than one autoimmune disease, including NMOSD or MOGAD. Anyone? You could, and even if you don't have NMOSD or MOGAD, if you have more than one autoimmune disease, okay. Okay. All right. Back to you, Dr. Sotirchos. If you have one, you come on up, Brenda. Welcome. Thanks for being here. This is Dr. Brenda Banwell. She's from Hopkins Medicine. You want to introduce yourself?
Hello. Sorry about that.
No worries. She has a new puppy.
Yes. My apologies. My husband and I are juggling our day, and we have a 6-month-old puppy, so I had to be a little bit later than planned.
Don't worry. Thanks for being here. Sorry, back to you. So if you already have, let's say, NMOSD or MOGAD, are you then susceptible to getting more autoimmune diseases just because you have one already? Because we see a lot of Sjogren's, lupus, a lot of our patients have that too.
Yeah, no, that's a great question. So in general, often people with one autoimmune disease are more likely to have another. So there is some shared genetic predisposition potentially to autoimmune diseases, but it does differ quite a bit between NMOSD and MOGAD. So with NMOSD, it's been recognized that there is a very high tendency to autoimmunity. And as you just mentioned, there is a subset of people who will have often overlap with rheumatologic diseases. So as Dr. Shin mentioned previously, lupus, which also has a very high predisposition for females. So again, NMOSD, aquaporin 4 seropositive NMO, about 90% of patients, up to 90% are women. And that's kind of a similar situation with lupus in terms of a very kind of strong predisposition for females. And so in NMO, it's been recognized that up to 30% of people with NMO will also have a rheumatologic disease or another autoimmune disease overlapping, often lupus, Sjogren, things like autoimmune thyroid issues as well may overlap quite a bit as well. And then it's also been recognized that even in people who don't actually have clearly that disease, if you test their blood for antibodies that are associated with those diseases, it may be more than 50% of people with aquaporin 4 IgG seropositive NMO who will be positive for some of these antibodies, even if they haven't developed symptoms yet of them. So there is a very high tendency for autoimmunity in people with NMO. And then there are genetic studies that have shown that some of the genetic risk factors are shared between NMO and lupus. So there seems to be a common kind of thread there. Now with MOG antibody disease, in our experience, and there have been now a number of studies looking at this, although again it is a rare disease, we're not seeing that, I would say, to a significant degree. I have some patients who have overlap, but it is much, much less than what we see in neuromyelitis optica, and it does not seem to be kind of co-occurring more than chance, I would say, in terms of rheumatologic diseases coexisting.
Great. Dr. Banwell, thanks for joining us. Happy to see you. Let's talk about the R word, relapse. Obviously, none of us want that.
Right.
So I have a twofold question for you. The first is, what happens to a patient when they're having relapses? Like, what are the symptoms? How do they present? And then furthermore, are there any predictive markers for relapses? Is there any way that we can see it coming?
Okay, so before I answer that, if I could, I just want to jump on one quick comment about the shared autoimmune story, because I get asked this a lot. So far, to my awareness in MOGAD, we've not seen particularly familial MOGAD, so a brother and a sister, a parent and a child. And because it's rare, we even pretty uncommon to hear about cousins or distant relatives with MOGAD. And that's a big deal, because a lot of times I will have a parent who has a child with MOGAD and they're really worried about all the other children in their family. And we're really not seeing familial MOGAD, which is quite different than multiple sclerosis, where the rate of multiple sclerosis can be 3 to 5% in family members and 30% likelihood of both twins being affected. If one has MS, the other co-twin has a 30% chance of being diagnosed with multiple sclerosis in their lifetime. But in MOGAD, we're just not seeing that, and I just want to emphasize that point because I think it's something that's on people's mind quite a bit. With respect to the R word, none of us like the R word either. So unfortunately, I'll start with MOGAD. We've been looking really hard at the best way to predict the likelihood of having a second or third event of MOGAD. And so far, despite our best efforts, we're not finding that. So one really important feature that people have looked at is the titer, or how much MOG antibody is in the blood. And I will remind everybody that the best place to test for MOGAD is in the blood. The MOG IgG is most diagnostic in the blood. There may be a role for spinal fluid testing down the road, but that's not how we make the diagnosis. You can have someone that has a blood value of 1 in 10,000, which means you'd have to keep diluting over and over and over again to wash out the MOG IgG, and that's considered a high titer. And someone else might be 1 in 100, so a lot easier to dilute that out. That does not tell me whether or not the 1 in 10,000 person or the 1 in 100 person is the most likely to have a relapse. And I say that at every conference, and my colleagues and I share that point, because there is a tendency to say it must be worse. If I'm 1 in 10,000, I should be on stronger medicine. I need to be on medicine when I've only had one event. And based on that value alone, that is just not true. The data does not support that. The best predictor of relapsing disease in MOGAD is if you actually have a second event. The other thing about MOGAD, very different than multiple sclerosis, is it's extremely uncommon to have new changes on an MRI, particularly of the brain, that aren't experienced clinically. So if we do MRI scans, and we did in one of our studies, every 3 months for the first year, every 6 months for the second year, every year thereafter, and in this particular example, we're at year 17, the MRI is a poor predictor. Only 4% of all the scans we did in patients with MOGAD, where the person was perfectly fine on the day of the scan, was there even a hint of anything new? And when we looked at those new things, they weren't attacks. They were tiny changes that you might get with a migraine or with having a bump on the head. They were not MOGAD changes. So in multiple sclerosis, on the other hand, you can have about 9 new changes on your MRI, and that's a strong predictor about relapsing disease, and multiple sclerosis is a very different disease than MOGAD. So MRI, which is so helpful in MS, is not so helpful in MOGAD. And it's not particularly helpful in aquaportin 4 neuromyelitis optica spectrum disease either. So our best window into the nervous system with MRI isn't a tool in MOGAD. So that's a long way of saying we have no way of predicting relapses. And I should shorten my comments. But we simply don't have that, and that's really important to know.
Just a follow-up question. If a patient is experiencing a relapse, what are the treatments that you offer?
All right, so first is recognition, because if the faster we see you, the more likely we are to help make you or your family member better. And so relapses in MOGAD and very similarly in NMOSD more broadly can affect the nerve to the eye, so visual blurring, dimness, having trouble distinguishing red in particular. It looks brown to people that are having an optic neuritis event. Pain with eye movement, so looking side to side causes some discomfort. And of course, reduced vision, like if you actually test visual acuity. If you have attacks in the brain, you can imagine there's quite a lot of things you could experience, but particularly numbness or tingling in one arm, one leg, or the whole side. You could have an attack in the back part of the brain, which might impair your balance or coordination. And you can have attacks in the spinal cord, which often will lead to symptoms below the level of the inflammation. So both legs, for example, if it's in the middle of the spinal cord. And then something people don't tend to share very easily, but very important, is bladder issues. So trouble controlling bladder symptoms, completion of going to the bathroom and having to go right back and void again. And not usually a presenting first symptom, but definitely a symptom that we need to talk about, can be things like erectile dysfunction and sexual dysfunction, especially if the lower spinal cord was involved. Rarely the first symptom in an attack, but an important symptom nonetheless, because of course it's treatable.
Thank you.
Oh, and then I didn't tell you what to treat with.
Yeah, please.
So we still start with typically with intravenous high-dose solumedrol with methylprednisolone, which is a steroid. If the person doesn't respond promptly to that, then often we'll move to immune globulin. Intravenous immune globulin is often quite helpful. And then if we have what we refer to as life-altering attacks, so a really severe event, we certainly move to plasma exchange promptly, because we know that that can be extremely helpful in an acute event. And then finally, honestly, my last answer, if someone has life-threatening MOGAD attacks, or attack, this rarely happens twice, and certainly we've seen this mostly in children who can come in with brain swelling as their event. This is rare, so please do not panic. This is an uncommon event, but tocilizumab, or for those that are into the names of these things, an anti-IL-6 receptor therapy can be life-saving. And the critical point to that is recognition.
Love that. Thank you. So to prevent relapses, in the case of NMOSD, there are now 4 FDA-approved therapies that work really well. You can learn more about them today. We have some sessions on them, and then, of course, the booths are back there. When I got diagnosed 11 years ago, there was nothing, and now we have 4. So this is huge, and it's, I think, completely changed the trajectory of NMOSD in terms of relapse prevention. I want to ask the panelists, how has it changed in practice for you? Because it must be huge. When you all started, none of these drugs existed, and you were resorting to, all different kinds of off-label therapies. But now there are 4 that are highly efficacious. So how has it changed your practice in terms of treating patients? Anyone can answer this.
Can I jump in quickly? Sure. A plug for Dr. Sotirchos.
Yeah, the Timely Plex trial.
Yeah, just to Dr. Banwell's point, the idea of how to best treat an attack of something like NMOSD is being examined, and so you should say something.
Yeah, talk about the trial.
Yeah, definitely. So currently, we're at a crossroads in terms of how to treat acute attacks. And so the traditional kind of approach is to give steroids and wait and see if someone improves. And then if they have not improved with the steroids, to kind of escalate to the treatment to do plasma exchange, for example. And that's kind of the more traditional approach. On the other hand, it kind of makes sense that if you were to do plasma exchange earlier, that could potentially kind of save more nerves from being damaged. And so there's increasingly kind of a push to potentially do that earlier, although we have to recognize that plasma exchange can also have complications. So it involves often placing a large central line, which is essentially a venous catheter, into one of the large veins in the neck, so an IV essentially, a very large one. And that can cause complications like bleeding. It can clot sometimes. People, when they're having the plasma exchange, their blood is run through a machine that removes a lot of the clotting factors, and that can lead to bleeding. So we have to kind of understand how to balance the risks and benefits of this. And so because we were very interested in this question and there haven't been any trials really examining it, it's all been based on seeing what happened and then saying, well, this person got Plex earlier, this person got it later, let's compare their outcomes. But they're not really the same thing, because there's a reason somebody got Plex earlier or later, and you can't really tell unless you do a trial where you flip a coin, half of the people get the treatment early, half of them get it late. And so because of that, we recently obtained funding from an institute called PCORI that Sumaira mentioned previously, that's funding various kind of trials in order to examine how to use these interventions. And we're embarking on a clinical trial across 30 sites in the United States now, randomizing people not only with NMO, but any sort of acute optic neuritis or myelitis, so inflammation in the spinal cord or optic nerve, to receive plasma exchange early on or to receive it after they get steroids, and seeing which approach may work better and what the risks and complications are in each group. So that's something that we're really excited about and we'll be embarking upon very soon.
Great. So the drugs, how has it changed how you guys, treat your patients?
Okay, well, I mentioned I'm old enough to remember when I learned about MS and there were no treatments for MS. And we didn't even know about NMOSD or MOGAD at that time. And we're in this fortunate position with over 25 different options for the treatment of multiple sclerosis. That's super exciting. And then, as you mentioned, we now have the ability to distinguish between multiple sclerosis and NMO spectrum disorder and MOGAD. And NMO spectrum disorder now has 4 FDA-approved therapies. But what I think is fascinating is that they don't overlap. Mm-hmm. So the FDA-approved treatments for MS and the FDA-approved treatments for NMOSD are different. And so that, again, emphasizes the importance of us getting the diagnosis correct. Mm-hmm. And then, as Dr. Banwell already hinted at, with MOGAD, we're still trying to figure out how to best treat it. But again, the importance of actually getting the diagnosis correct. So it's an exciting time, but we still have some work to do. I was going to say maybe one other thing, at least in the MS world, which is a little bit disturbing. We said we think maybe 1 million Americans have MS. We have literally dozens of awesome treatment options for the treatment of that. Data tells us that still the majority of Americans who actually have a diagnosis of MS are not being treated. There's still, whether it's because they don't have access to an MS specialist or even a neurologist, or just due to maybe lack of getting that information out there. And I worry that that must be as common an issue, if not worse, for these rare diseases, that all of these advances that we are hearing about may not have filtered down into the community. And it's so important because of how effective the NMOSD treatments can be, that we identify those individuals with the condition and make sure they know how important it is to be on treatment.
I can add just a couple points for pediatrics and let my colleagues also join in. We live in the world of off-label use, right? We have always lived in that world. The studies historically were not done in pediatrics, and there's a lot of reasons for that, and reasons that make sense, right? It's much more difficult. There's a lot more ethical things that we have to take into account, right? And just we are now getting to the point where those studies are starting and really moving forward in the MS world, and then the NMOSD and the MOGAD world is sort of coming up behind that. And so I think that in the near future, we're going to have FDA or more FDA-approved options. We have one in MS right now. We should have many more soon, we hope. But that is what is sort of typical for us. So everything that we do, we're doing also a little bit behind the adults. We're seeing what the adults are doing. We're seeing, is that going to be safe in our kids? We have to think about what is it going to be like 10 years from now, 20 years from now, when this 6-year-old is 26 years old, right? And so there are a lot of these other considerations that come into play. But at the same time, the options that we have in pediatrics are also so much more than they were in the past, and we're seeing much better outcomes as well. So I think we're learning a lot from the adult world, and we're learning how to bring that into the pediatric realm a lot earlier. We're also treating more quickly, more upfront, and I think we're seeing better outcomes from that as well. But it's overlaps, but slightly different. So when you say we have all of these new medications for NMO, we don't in pediatrics. And we have good success using things like rituximab. And safety-wise, we're also seeing really good outcomes. But at a certain point, there are additional side effects that come with that. And then we are working on switching kids over to other medications, right? And then when it's not FDA approved and it's not seen in kids and it's all off-label, there are other complications that come into that. So, a lot of our families have worked really hard in those areas. But great options, just a little bit different.
Yeah. Just a comment on the clinical trials for children. I do think we're going to have more advances for pediatric onset neuroimmune diseases, MS, MOGAD, and aquaportin 4. But unfortunately, it isn't quite as far as I would like it to be. And this is really challenging. So I sit on the international leadership level of the MS group and the Multiple Sclerosis International Federation. And in wearing that hat as the medical director of the International Federation, I have the opportunity to look at how things are going across the world. And one of our biggest challenges, and this is particularly a problem for pediatric trials, is that the European approval agencies and the US agencies do not agree. And as a consequence of that, each trial has to be designed to meet the needs across the ocean, and the approvals do not line up. So, for example, one medication, which I don't think is changing the face of pediatric MS anyway, so it was probably not the biggest treatment that we would have wanted, but it illustrates the problem. That medication, which is called teriflunomide, was approved in Europe, but it's not approved in the US. The biggest trial done in multiple sclerosis for children, which is comparing an anti-CD20 therapy called ocrelizumab, it's like rituximab, to fingolimod, which is the only medicine that's approved, is facing major challenges right now on what the regulatory authorities want to see for both of those outcomes. And so to put it in context, we advocate over and over and over again for the safe inclusion of pediatric patients in clinical trials. Safety is always first. We're pediatricians. But there's a lack of safety that comes with a trial not considering children and with the fact that we are probably 15 years behind where the adults are for the armamentarium of clinical trials. I mean, in the last 15 years, there are 25 approved therapies for adults, and there's one for children in MS. The treatment trials that are coming forward in aquaportin 4 disease and MOGAD, at least one in each space, is approved to include 12-year-old and up, which is a major step forward. Because if we can include teenagers at least who really do not differ biologically, they differ on all sorts of other things, as parents know, and we all know that, but they don't differ biologically, to the best of our ability to tell, in how they respond to medications. We've added extra safety features to those trials to be really sure that what we're doing is okay. But in terms of access to these life-saving therapies, it is a huge safety issue that children do not have access for 10 to 15 years longer than adults. So for all of us that advocate, and I know many of you are part of that, we need to be able to gain access to these treatments for kids too.
We're going to put a pin on that and dive deeper in our afternoon session because, as it's very clearly been outlined, there are so many unmet needs, especially in pediatric care. So, Nell, you have to have some hard-hitting questions for these doctors later. I want to make sure we have time for questions from the audience. Does anyone have a question? Raise your hand. Someone will come around with a mic. Don't be shy. Okay, Michael, of course he does.
So maybe just a quick question on MOGAD. What's the situation for treatments for MOGAD? What's in development? What can MOGAD patients look forward to potentially?
I'll tell you for kids, you go for adults. So first thing, we need to remember that all MOGAD patients need to be treated when they have a relapse, in my view. And by treated, I'm using that term broadly. They need to be examined. They need to be, the severity of the attack needs to be considered. We need to be thorough on whether someone's actually having an attack. And if anyone in the room has experienced some features of MOGAD, sometimes it's not actually an attack. You might have some visual blurring because it's really warm outside. You might have a brief set of symptoms, and after a thorough exam, we reassure you that it's not actually a new event and we don't have to give medication. We still treated you because we saw you and dealt with the symptoms. But if there's a new actual attack, then we want to get the acute symptoms resolved, and as we just heard, there's some wonderful studies in that regard. Following that, not all MOGAD patients need to be on lifelong therapy. If they have not had relapsing disease, we are not putting patients on chronic treatment. We would treat people for years for something that's not going to happen to them. So we would love to know how to predict who is destined to have a second event. But until they do and declare themselves, it is generally not advised to put someone on chronic therapy. There's a few exceptions. If someone has a life-threatening MOGAD first event, many of us will put them on monthly immune globulin for 6 months to get them out of that acute window, just because they have a recovery period that we want to also protect them through. But that's not the same thing as chronic therapy. For prevention of attacks in relapsing MOGAD, I think the exciting directions, particularly around the anti-IL-6 receptor family of therapies, are the most promising. And that's based on good data that patients with MOGAD and aquaporin 4 disease have high levels of interleukin-6, at least in the spinal fluid. So that's the most exciting direction. There's a few others, but I think that's the most relevant.
Yeah, and so this is definitely a very important distinction that in contrast to aquaporin 4 positive NMO, where generally lifelong treatment is recommended for people who are aquaporin 4 antibody positive, and MOGAD, not everybody needs to be treated. Now, we are currently using a lot of off-label therapies because there are no FDA-approved therapies, but there are 2 ongoing phase 3 clinical trials right now that we're waiting for results. That will probably take a couple of years for those trials to be completed, but they have been recruiting for some time now, specifically looking at 2 agents. One is satralizumab, which is FDA-approved for the treatment of aquaporin 4 positive NMO, and now being studied in MOG antibody disease, and that specifically targets that pathway that Dr. Banwell just mentioned, the interleukin-6 receptor. So we're quite hopeful that that will be a positive study, as well as the clinical trial of something called rozanolixizumab, which is also in a phase 3 clinical trial, but this one is not including pediatric participants, so the satralizumab one is, so that's in adults with relapsing MOGAD, and that one acts quite a bit differently in terms of actually removing antibodies from the bloodstream, kind of like doing Plex to some extent, if you think about it, but through giving a medication, actually. And so we're quite excited that I think that it's very encouraging how quickly, I would say, compared to when MOGAD was discovered as a disease. Diagnostic criteria were published just in 2023, but actually the clinical trials started before diagnostic criteria were published. This is in contrast to NMO, which was recognized as a distinct disease in 2004, 2005, and then the first clinical trials, phase 3 clinical trials, were over a decade later when they started. So I think that it was very nice that the infrastructure and the understanding of NMO, because of the similarities of NMO and MOGAD that we discussed previously, were there, and we already had an understanding of how to design these clinical trials. So it enabled a rapid startup of clinical trials in MOG antibody disease. So it benefited a lot from the experience with NMO.
We have a question up front here.
These are NMOSD questions. First one is for diagnostic AQP4, CSF fluid versus blood. Is there a scenario where you can just do a blood test? Secondly, in patients who are on rituximab, what is the threshold for starting IVIG in terms of infections on patients with rituximab? So thanks.
I can take that. So in terms of the diagnostic testing, so with NMO, blood testing is sufficient. It is the most sensitive, and actually testing only spinal fluid could miss many, many cases of NMO. And so definitely blood needs to be tested. Now, many years ago, there was a thought that maybe there existed some patients who were positive in the spinal fluid but not in the blood. But it's become recognized that that really doesn't exist. So blood testing is sufficient, and blood testing is what should be done. And unfortunately, this is an area I feel that we still need to educate general neurologists out in the community, because I've still seen cases, even as recently as last month, coming to me with seronegative NMO because they were tested only in the spinal fluid, and then when we tested in the blood, they were positive. One other consideration with the blood testing is that there are different tests that are used. One is called an ELISA, which is kind of an older test, but it's still offered by many commercial labs. Then there are the cell-based assays, where there are cells that have been made to express the aquaporin 4, that protein. And then even the cell-based assays, there are two types. One where the cells have been kind of put on a slide and fixed with formalin kind of, and that kind of makes the cells just stay there. That's very convenient, because then you can just have this kit that you ship around the world. It can sit for months, and then you test it whenever you have a blood sample, versus kind of what are called live tests, where you actually have to have the cells and you have them in a dish, in a culture, and you have to take care of them. And this is done at specialized centers. And so there is varying performance between those tests, and so that's an important consideration sometimes. If somebody's negative by the ELISA assay, which is the oldest and kind of most easy one to do, that doesn't mean they necessarily have seronegative, quote-unquote, NMO. If they're tested by by a better assay, they might end up being positive. Now, in terms of the IVIG, there's no hard and fast rule, I would say. In general, my threshold would be if somebody is experiencing kind of recurrent infections. And also, often what happens is it ends up being not necessarily a recurrent, but almost like a persistent chronic infection. So you'll see somebody have a pneumonia or even just a bronchitis that's kind of mild. They get treated with antibiotics. It gets a little bit better. Then it comes back again. So it's kind of like they're almost continuously sick for months at a time. And they can have recurrent sinus infections or ear infections kind of occurring. At that point, when that's occurring and it just doesn't go away even with a course or two of antibiotics, that's when I start considering the use of IVIG. And typically these patients will have low antibody levels in the bloodstream. So we test their bloodstream for antibodies. Specifically what we're looking at is the level of an antibody called IgG. Generally, most people who develop these sort of recurrent infections that are due to the low antibody levels from being on rituximab or other medications like that, they'll have levels below 600. And then we start the IVIG and can give supplemental IVIG. The doses are pretty low. We typically dose it every 1 to 2 months. But one thing to recognize that if somebody is on rituximab, even spacing it out or even stopping it, they still may need IVIG even for a few years after stopping, because it takes time for their B cells, which are the ones that make antibodies, to come back. So it is an important kind of discussion. And then you have two options there. It's kind of continuing the treatment, because NMO needs to be treated lifelong, as we said previously, concurrently with the IVIG in order to prevent infections, versus switching to something else in order to allow those B cells to come back. So there are a lot of considerations that come into play there.
Okay, I think I saw a question. The woman in the white right here, yeah.
My daughter's just diagnosed a month ago, so this is all new to us. My concern is research and the things that you find on Google. Inflammation is a major part of this. Does your diet, any research been done on your diet, the anti-inflammatory diet, to help with the disease?
I can take that one. So First of all, we all get information now from multiple sources. I'm sure every one of you have Googled symptoms. All of you have probably spoken to people you trust. Family members, with the best of intention, will bring information to you. This is both excellent and wonderful because we then have a shared set of information. But my plea would be, anytime you think about starting something, please talk to your doctor about it first, because there can be some information online that is counter to what we would want. So I'll talk about diet briefly first. First of all, lots and lots of studies have been done to say, is there a truly anti-inflammatory diet? And I think the majority of evidence would say no, frankly. We all benefit from a healthy diet. We all benefit from good nutrition, balanced nutrition, exercise, and wellness, and that does matter in any of these conditions. There is good evidence that when people are more active, nutritionally, getting a balanced nutrition, that they do better overall, but not because any one ingredient is anti-inflammatory. Vitamin D has been studied the most, and people with very low vitamin D levels in the circulation can show, when we test their blood specifically, and more accurately test their immune cells, that their immune cells are more inflammatory in the way they behave. And so that has led to a lot of us recommending that people take vitamin D in order to make sure their vitamin D levels are in the healthy range. I'm not aware of any study ever that has suggested having a healthy, normal vitamin D level is bad for you, whereas not having healthy vitamin D is bad for your bone health, your muscle health, your immune health, and so I think it's a logical thing to make sure people's vitamin Ds are in the right range. And probably most people in this room have a low vitamin D level, because 70 to 80% of Americans have low vitamin D. We don't take it in our diet reliably. The vitamin D fortified milk, you'd have to drink, I'm Canadian, so here I go, 3 liters a day. I need to convert that to gallons. The amount of milk you'd have to drink, or yogurt, or vitamin D containing foods, is just beyond what most people consume. Fatty fish have a high amount of vitamin D, so salmon, herring, that kind of fish, but most people do not eat enough of that to bring up their vitamin D. So vitamin D as a vitamin is one thing we recommend. If people have, particularly more the NMOSD aquaportin 4 family of conditions, and by chance also have gluten-sensitive enteropathy or true celiac disease, then we would all agree that following a gluten-free diet is good for those people. Not necessarily because it makes their aquaportin 4 neuromyelitis optica spectrum disease better, but because it makes them better in general, right? If you have gluten-sensitive enteropathy, stomach disease, you're not going to feel well if you're taking gluten. But otherwise, bee venom, the swank diet, diets that are rich in B12, diets that are low in animal fat, diets that are lower in carbohydrates, diets that are higher in carbohydrates, they've all been tried. And there's no systematic evidence that any one of them is better than just an overall well-balanced, healthy nutrition.
On that note, I am getting the look of death, the other vitamin D from the corner over there. We are way over time, but our lovely doctors are here, hopefully, for a bit. So if you have questions during the breaks, during the lunches, you can ask them. And of course, we have other sessions. But please give a round of applause for these wonderful doctors who have joined us here today.